The suturing technique that is being shown was selected after the periodontal osseous surgery had been completed. This technique is one which will permit suturing of the buccal flap independently of the lingual or palatal flap. It is performed with a continuous suture, which is initially secured at the distal end of the flap. One end of the suture is cut off. The needle is then passed interdentally below the contact area. The suture is brought around the lingual aspect of the first premolar and carried back through the interdental space on the mesial side of this tooth. Then the needle is placed through the interdental papilla between the canine and the first premolar and carried back to the palatal side. The suture is brought around the lingual of the canine and back through the interproximal space between the canine and lateral incisor. The needle is inserted through the labial aspect of the interdental papilla and carried back through the same interdental space to the lingual side. This suturing procedure is repeated with the central incisor, but this time making sure that there is enough slack kept on the palatal strand so that when the needle is passed back to the lingual aspect, the suture can be tied. The same suturing procedure is repeated on the palate to immobilize the palatal flap. This suturing technique adequately secures the flaps and assures close adaptation of the soft tissue to the teeth and bone. The margin of the flap is approximately 1 millimeter coronal to the alveolar crest. Using independent sutures on the buccal and palatal flaps is necessary because these flaps will be placed at different heights on the teeth. If a single suture joined the two flaps together, it would not be possible to locate them precisely. This same procedure, using several independent sutures rather than a single continuous suture, would have achieved the same results. Close adaptation of the flaps to the underlying bone and root surfaces is desirable to enhance healing and reattachment. This approximation will also prevent the periodontal dressing from getting under the flap. Teflon-coated sutures may be substituted for the silk sutures used in this demonstration. However, these plastic-covered sutures are more prone to untie and require 2 or 3 extra knots. After the palatal tissue has been secured, distal wedge incision is closed. Note how the removal of this small wedge has eliminated any soft tissue overlap distal to the premolar. The area is covered for 30 seconds with a sterile gauze dipped in warm water. This further adapts the tissue to the bone and helps to eliminate any submucosal hemorrhage. The sutures are carefully checked to make certain that the soft tissue flaps are properly secured. There appears to be adequate closure of the soft tissue distal to the premolar with a minimum of underlying osseous tissue exposure. The packing that is initially placed over the buccal and palatal surfaces is a non-eugenal dressing of the Baer-Sumner formula. It is softened in hot water, placed on the buccal and palatal aspects, the pack is locked interdentally with college pliers. The stability of the flap will be further ensured the use of a zinc oxide and eugenal preparation. This Kirkland type placed on top of the first dressing. The pack is muscle trimmed to eliminate overextension. Adhesive foil is placed on site to help protect the dressing during the next few hours. It will harden. This is the area 5 months later. Probing on the buccal surface shows that there are normal crevices about 1.5 millimeters deep around the teeth. The gingival form is physiologic, and there is a sufficient zone of attached gingiva present. The gingival tissues are firm, and only minimal bleeding accompanies probing. The gingival contours on the palatal aspect show that the deep defect between the premolars has been eliminated and replaced by a shallow crevice. Physiologic gingival form is present throughout. The tissue, distal to the second premolar, rises toward the tooth, which is the normal contour for this area. Restorative work can now be initiated to replace the temporary aid splint. morphology of this defect guides the clinician in selecting the osseous surgical method for its removal. Therefore, by osteoectomy, this one wall will be removed and the infrabony defect eliminated. The buccal flap is now going to be reflected. This is a full thickness flap reflected by a periosteal elevator. It will permit access to the underlying osseous tissue and at the same time will retain the zone of attached gingiva on the flap. Reflecting the flap enables the clinician to see the pattern of the underlying alveolar crest. Water spray is used to remove any debris fragments. The defect is now seen between the two premolars from the buccal aspect. Having cleaned out the soft tissue fragments with a curette, this pocket will be eliminated by the use of hand and rotating instruments. The instrument being seen is an anterior curette, removing fragments of soft tissue left behind. Osseous nippers are used to remove a small piece of your dental septum and reach the bottom of the defect. This begins the contouring of the interdental problem between the maxillary first and second premolar. A vertical groove or spillway is created with this instrument. A curette is again used to remove any loose pieces of bone and any remaining soft tissue fragments. Care is taken to try and create physiologic osseous architecture. This term implies that the interdental septum extends more occlusally than the adjacent buccal crest. This is the shape the bone had prior to the development of the defect. With a Wiedelstadt chisel, further osseous contouring is accomplished prior to the use of the rotating burr. The double-ended Wiedelstadt chisels are useful instruments in attempting to eliminate one-wall defects interdentally. The chisel may be worked from the buccal and go completely through to the palatal aspect. It can also be contoured from the palatal side. Coarse diamond stones are used for osseous contouring. One should be careful to use a water spray and place very little pressure on the osseous tissue. It is important to be careful of the tooth structure in the area so that gouges or irregularities are not made in the tooth surface. The accentuation of the interdental groove is also accomplished between the canine and the first premolar. This will be repeated in other areas. Debris fragments are removed by the curette and irrigation. Use of the ocean beam chisels 1 and 2 enables the clinician to create physiologic architecture in this premolar region. Cures again are repeatedly used to remove any loosements. The same procedure is repeated on the palatal aspect in an attempt to eradicate the bony defect between the two premolars. Here we see the ocean beam chisel being used on the palatal aspect to correct the bony contour between the premolars. Examining the osseous tissues from the labial and buccal, one notes that the contour has been improved and that a rise intervally exists between the two premolars, whereas before this was reversed, in that the interdental tissue did not come down occlusally as much as the adjacent buccal and lingual crest. The interdental grooves are noted. The flap will be positioned about 1 millimeter occlusal or incisal to the crest and secured with either continuous or interrupted sutures. Suturing and positioning of flaps is demonstrated in part 2 of this film series. Suturing technique being shown was selected after the periodontal osseous surgery had been completed. This technique on which will permit suturing of the buccal flap, independent of lingual or palatal flap, performed with a continuous suture which initially secures the end of the flap. One end of the suture is cut off. The needle is then put indentally below the intact area. The suture is brought around the lingual of the premolar and carried back interdental on the mesial side of this tooth. Then the needle placed the interdental papilla between canine and the first premolar and carried back to the palate. The suture brought around the lip of the canine and back through the proximal base between the canine lateral incisor. The needle is inserted through the labial aspect of the interdental papilla and carried back through the same interdental space to the lingual side. This procedure is repeated central incisor, but making sure there's enough slack on the palatal strand so that when the needle is past the lingual effect, suture can be tied. The same suturing procedure is repeated on palate to immobilize the palatal flap. This suturing technique actually secures the flaps and assures close adaptation of the soft tissue to the teeth bone. The margin of the flap is approximately 1 millimeter coronal to the alveolar crest. Using independent sutures on the buccal and palatal flaps is necessary because these flaps will be placed at different heights on the teeth. If a single suture joined the two flaps together, it would not be possible to locate them precisely. The same procedure, using several independent sutures rather than a single continuous suture, would have achieved the same results. Close adaptation of the flesh to the underlying bone and root surfaces is desirable to enhance healing and reattachment.